So our presentation that we're going into is radiation safety in the OR environment. I have Mr. Edwin Giles here, and he is the Assistant Radiation Safety Officer at St. Luke's and Texas Children's for 14 years, and a Radiation Safety Officer for 5 years. He's a Senior Imaging Physicist at Houston Methodist for 2 years. He is board certified in the American Board of Radiology and Diagnostic Radiology Physics, American Board of Science in Nuclear Medicine and Nuclear Medicine Physics and Instrumentation, and the American Board of Science in Nuclear Medicine in Radiation Safety and Protection. Please help me welcome Mr. Giles.
Thank you. This on? Can you hear me in the back? You can hear? Okay, very good. Thank you, Jennifer. Probably one of the most important lectures today, because after this is lunch. So let's get through this and get you on to, looks to be a good lunch outside. What we're going to do is talk in general terms about radiation, specifically X-ray, specifically, we'll then focus into the OR environment. We'll look at various radiation-producing devices, of which there are tons of X-ray units in the Houston Methodist system. We'll look at possible effects and dose terminology, look at occupational and patient doses. As occupational workers, when we're around X-ray units, what is our exposure? How much is too much? What do we expect given the workloads you guys perform? We'll look at the golden rules of radiation safety, and then finally just overall risk involved. So we're looking at technology that was discovered in 1895, 120 years old. We're looking at technology that has evolved to some degree from the early times. The first X-rays in 1895. You have to think about, that was probably pretty cool technology. Up until this point, no one had ever seen inside the human body unless the human body was cut open or you broke a bone, the bone was sticking out. The ability to actually see something inside of the body, that's pretty fascinating technology. Well, as you can imagine, early researchers were all over that technology, and before long they begin to see effects. And ultimately, this idea of protection occurs. The protection we wear certainly is not as bulky and bad as this, but we do in fact have, of course, lead aprons that you guys are involved in wearing in many procedures. Not to get too technical, but the term radiation, the term electromagnetic spectrum, what does it mean? In the whole scheme of things, the ability for our eyes to actually see is in a visible light spectrum. So the light we see has a certain wavelength, it has a certain frequency. When you're at home heating up your food, you use microwaves. When you're driving down the road, we have radio waves, these huge waves that we don't see, but they hit our antenna. We have music to our ears. And then finally, we're going to focus on something that has a very high frequency, low wavelength, basically X-rays and gamma rays. We'll focus just on the X-ray portion. I didn't mention, but in that whole scheme of radiation, you have ultraviolet and infrared. So those technologies can be used, and we begin to see more used in the medical environment as far as the ultraviolet and infrared. So when we look at X-rays, let's look at the underlying technology of what's going on. We have a situation, we don't see this because it's covered up, but we have basically something called a filament, and it takes electrons, lots of electrons at a very high energy, and they hit something called a anode. And here's a picture of an anode. This anode is a device in current technology. It actually spins very fast. And these electrons are hitting the spinning anode. The reason for the spinning action is the amount of heat inside of these X-ray tubes is huge. It's a lot of heat. Way over 90% of the energy involved here produces heat. It's a very small percent of this interaction where we actually have X-rays that are produced. This slide is a little deceiving, and it makes it look like X-rays are just coming out of basically the port here, when in fact X-rays are generated all around the tube. So you may think, well, if I'm standing near the tube, even though I don't see this, am I getting exposed? The answer is a very small amount, because these tubes are so well shielded with lead that the amount of leakage out of the tube is just almost non-existent with today's tubes. So what we have to not worry about, but think about is, for the most part, the x-rays are coming out just out of the port of the x-ray tube. In radiology as a whole, not to mention the OR environment, but in radiology, we certainly are used to seeing CT units. We're used to seeing radiographic units. If we have a broken arm or something, we're gonna take an x-ray. This is an RF room where you can do both fluoroscopy and also there's a rad tube. We have mammography. We have either a general angiography interventional type suite or a cath lab. And then finally, we have portable devices, portable radiographic, portable C-arm. A couple points. Radiographic imaging is a almost instantaneous image, right? So if you go in, they need to check, see if I have a broken arm. Quick shot, it literally lasts milliseconds. When you guys are in the OR environment, when you're using portable C-arms or you have some sort of a suite that's an interventional suite, when we're dealing with fluoro or fluoroscopy, we step on a pedal. And as long as our foot is on that pedal, x-rays are being generated. Unlike radiographic, where it's instantaneous, fluoro can go from now till the end of the day, assuming the tube doesn't blow up from being too hot. One comment on mammography, the technology has gone such that we now have, it's called DBT, digital breast tomosynthesis. And I don't know if anyone's had that in this room, but not only do you have your standard compression of the breast and kind of a AP and a medial lateral oblique, you now have the ability, or they have the functionality to compress the breast, and the x-ray tube actually kind of shifts. Of course, the breast is stationary, don't worry, it's not shifting, but the x-ray tube is shifting around, and it provides kind of a 3D type image for the radiologist to interpret. It's very useful for those that have a dense breast tissue, because the overlying tissue of that dense breast, they now have the ability to kind of see in layers. So this technology has come about the past few years, and I think it's really going to increase here in the next few years. In the OR environment, if we just look at this device, this portable C-arm unit, one may ask, where are the x-rays coming from? If I didn't know anything about it, I'd have no idea if the x-rays are shooting down or the x-rays are shooting up. In this case, most cases involve the x-ray such that the x-rays are coming from below the patient. Typically, we don't operate in a manner where the x-rays are coming down from the top through the patient and being captured. So this is primarily what you'll see. An exception to that would be if we have a cysto room. The cysto rooms are set up so the x-rays are shot down. In the cath lab or interventional hybrid suite, x-rays are typically down below, shooting up through the table, through the patient, and being captured at the image receptor. You and I, for the most part, we are not in the direct beam, right? We simply work in the room and we're potentially exposed to the scatter radiation. And we'll focus on this aspect very carefully. So there's tons of ways to think about it. If we get technical for a minute, the question is, how much exposure do I receive, okay? So if here's the x-ray table with the patient on the table, and if I'm at 1 meter away, okay, I'm exposed to about 1 to 10 MR per minute. We'll talk about in a moment that my dose limit, your dose limit is 5,000 millirem per year. So if the exposure at a meter was 1 MR per minute, I'd have to stand here for 5,000 minutes before I reach my annual occupational dose. If the exposure rate was 10 MR per minute, I would have to stand here for 500 minutes. So you can think about, all right, how many hours in a year do I work? How close am I to the x-ray tube? It's a dynamic situation because I'm actually not going to stand still for some amount of time. I'm moving around. Sometimes I'm closer to the table where the x-rays are scattering from. Sometimes I'm farther away. Why do we care about radiation from our perspective? Well, the potential is that we can have damage to basically our DNA through a direct or indirect effect, which can cause replications that ultimately leads to cancer. How do we know that? Well, there are certain data points that have occurred through time. Recall World War II, we had Hiroshima and Nagasaki. Recall in 1986, we had Chernobyl. That was a reactor in Russia or Soviet Union that blew up, had lots of dispersion of radioactive material. they now have population or data sets of individuals around that. And there's been some time now to where you can see if you estimate a dose to a particular person or population, and if you see an increased risk of cancer, you can basically have some data points. And what is shown is as the dose increases, the probability of cancer goes up in kind of a linear fashion. So if I'm exposed here versus if I'm exposed here, in this situation, I'm gonna have twice the risk of cancer. So it's like, oh no, I'm in a field that's gonna potentially cause cancer to me. Turns out that you and I work literally way down on this dose scale. So even if there is a risk, it's a very low probability of effect. The ultimate issue or problem is, I've not seen data sets to suggest that she and I work around radiation for the past 20 years. We've received some X-ray exposure. In our population set, there has not been an increased risk of cancer. It's just not been shown. The experts say, well, we haven't been able to show it. We're gonna be conservative and say that, hey, even at a small dose here, there may be some increased risk of effect. So that's ultimately why we have radiation safety precautions. The other type of effect is something called a deterministic effect, where I can receive radiation, and all of a sudden, boom, I hit this point, and all of a sudden the severity of an effect occurs. So if this is an X-ray source, and I just put it right here and let it hammer my skin 1 hour, 2 hour, 3 hour, 4 hour, eventually my skin will turn red. That ultimately will get worse over time. The more I expose it, the worse the effect. And in that regard, it's much like being out in the sun. A little bit of sun, maybe a small amount of redness. If I'm out there all day without sunscreen, I'm in bad shape. It's going to burn bad. So radiation has a similar effect. As far as cancer, forget about radiation for a moment. We have in our society approximately a 40% chance of getting cancer. We certainly know friends and family that have received cancer. Of that, probably 20% will die from cancer. Now let's throw radiation into the mix, and lots of numbers here to make it very simple to understand. If we take a population of 10,000 individuals and give them 1,000 millirem, okay, the expected excess cancer risk is only 5 individuals. So in my mind, that is extremely low. We consider other risks, like me driving to the medical center today. The chance of being in a car wreck far exceed these kind of numbers. So even though we're going to take precautions, we basically are in a position where the risk is very low. In our field of work, fortunately, you don't have to deal with this. There are tons of exposures or doses. There's something called an exposure, an effective dose equivalent, a dose equivalent. Just be aware that you may see various units on your display devices. For example, in a room that displays the dose, you may see something in milligray. Realize that milligray is a term of radiation absorbed dose. The purpose of this slide is to just emphasize that you and I, if we were to be exposed, most of our radiation sensitive organs are in this region right here. If I'm exposed here in the head, down below, not as sensitive. And that kind of makes sense why we wear the lead aprons we do. Our lead aprons go from here down to here. Certainly if we want to be cautious, we could wear a full body lead apron. And I know we don't want to do that because of the amount of weight involved. Radiation sensitive wise, we're covered from head to toe, from neck to mid-thigh region. Keep in mind that you and I, just from living on this earth, are exposed to radiation. It's about 1 to 2 millirem per day. Keep in mind also your dose limit is 5,000 millirem. So we're all exposed. We have a dose limit, and then I'll throw in a moment the expected dose we receive from working here in the medical environment. When we look at our regulatory body, we're dealing with the Department of State Health Services. They dictate what radiation rules we must follow here in the medical environment. Recall I said your dose limit is 5,000 millirem per year. In another type of unit, that equates to 50 millisieverts per year. And then we're going to focus on declared pregnancy. Okay, so if we have an occupational worker, female of course, she becomes pregnant, her dose limit, if she opts to declare her pregnancy, drops from 5,000 millirem down to 500 millirem over the period of the pregnancy. The reason for that, as you can imagine, is the radiosensitivity of the embryo fetus is slightly more sensitive than we as adults. The question is, can we keep the doses down below this limit? And the answer is very much so. The use of the lead apron is very effective, on the order of 98 to 99% effectiveness. So if I receive 1,000 millirem and I'm not wearing a lead apron, she's wearing a lead apron, she's going to receive only about 1% of that, so that's going to be about, 10 millirem. So the ability to absorb the radiation is very good with the lead aprons, and so declared pregnancy is not a big issue as far as the amount of exposure that we receive. When we look at dosimeters, okay, the dosimeters we're typically going to wear in this region here. If I'm wearing a lead apron, I need to remember to put the dosimeter outside of the lead apron. So when I'm working around the radiation, I get exposure, that exposure is measured, and I'm gonna have some number, say it's 100 millirem. The radiation sensitive organs actually do not receive the 100 millirem, they receive 1 to 2 millirem because of the lead apron use. So when we look at our badge reports and we see a number, assuming I wear my badge at the collar region, it's actually an overestimation of the actual dose that I receive. So we can keep in mind, even though I show to have 100 millirem, in fact, the dose to my radiation sensitive organs is much less. We all have access to our dosimetry reports. It's broken up into your monthly reading, quarterly reading, and lifetime reading. So what about us? What about you individuals that work in the OR environment? Looking at data points through the years, an average nurse value, an average surgery tech, an average doc, we're looking at 50 to a few hundred millirem per year. And recall our dose limit is 5,000 millirem. So overall, the doses are well below the regulations. So our golden rules are time distance shielding. You've all heard this. The less time I'm around the radiation, the less exposure I receive. The distance effect is very, very beneficial. So here's the source of radiation, this water bottle. I'm being exposed. If I simply double my distance, my exposure just dropped not by a factor of 2, but a factor of 4. I double up again, my exposure dropped another factor of 4, so that's actually 16 times less than when I started. So simply moving, in this example, a few feet, my exposure dropped 16 times. So as you can imagine, the distance effect is very beneficial for us. The most beneficial, as we mentioned, is lead aprons. We're looking at 98 to 99% effectiveness. Any X-ray room in the hospital has lead shielding. The exception to that would be in certain rooms where you bring in a portable X-ray unit, right, or a portable C-arm. So certain ORs where you bring in portables, there's not lead in the walls. A dedicated room will have lead in the walls. As an example, the lead in the walls is usually about 1/32 or 1/16 of inch of lead, which correlates to about 0.8 or 1.6 millimeters of lead. So we're talking about very thin amounts of lead, but then the effectiveness of this is significant as far as reducing the exposure to any adjoining X-ray rooms or operating rooms. All right, so we spoke about us. We're expected to receive a few millirem per year. What about our patients? A patient in fluoroscopy may receive about 1,000 to 10,000 MR per minute. All right, so per year, You and I working around this scatter radiation, we receive a few hundred millirem. The patient localized dose could receive thousands of MR in just 1 minute. So quite a difference in their exposure versus our exposure. When we have rooms that have these, what we call cine or digital runs, that dose drop can be as high as 10,000 to 300,000 MR per minute. So we're talking huge numbers of localized dose to our patients. With these huge doses, even as far back as 94, 95, the FDA sent out a public health advisory basically saying, hey, we in the medical environment, we need to be careful on the exposure of our patients. This is actually from 94, 95. This is 6 to 8 weeks after exposure. This is 18 to 21 months after exposure to the same patient. So here's a nice bright slide. The potential effects from radiation go from skin reddening or erythema. We can have hair loss. We can have ulcerations. One of the important aspects is to have a process. Here at Methodist, we have a process. If a dose were to reach 5,000 milligray, then we file basically a PSN report. If the dose is 10,000 milligray, then the radiation safety officer performs a calculation. And then finally, a dose to a patient greater than 15,000 milligray represents what's called a sentinel event. So most any medical institution these days is going to have some process involved to deal with the radiation exposure to the patients. So we have to ask ourselves, what potentially causes high doses to patients? A very large patient, a complex case, a stationary beam, and basically no change in tube position. The larger I am as a patient, so if I'm only 200 pounds versus 400 pounds, the 400-pound patient will involve much more of an exposure because the X-ray unit senses, okay, I need to penetrate more. It produces more X-rays, more dose to the patient. So in the literature, even this is back in 2001, there's certainly several examples of radiation injury. This is probably the worst I've seen. This would have been in a cath lab where you have a biplane, both AP and lateral. For whatever reason, the patient's arm was left in the beam. The lateral tube basically just hammered the elbow region. Once again, this is back from 2001 in the literature. And these are just examples of radiation-induced skin injury where you're going to see reddening. If the dose is high enough, you may see the formation of ulceration. One thing to keep in mind on this is, say you're in a case and it's a complex case and you know for a fact you saw and experienced the fact that patient had exposure a long time. The foot was on the pedal. We're talking minutes, maybe hours of exposure. You're like, you know what? I once remember seeing a slide that was horrible where our patients may be injured. So you're like, well, let me go check the patient. You go look. Chances are you're not going to see anything. It's much like a sunburn. If I'm out there a couple hours, you're not going to see anything. Come back later this evening, all of a sudden my skin is red. It's very similar. The skin reddening will not occur for at best a few hours. The idea of ulcerations, there's no way we'll see ulcerations today. It's going to be days, weeks, months before that manifests into the overall effect. So just more examples from the literature. Let me reiterate that this is the exception, not the rule. 99% of our patients never have an effect at all. It's these rare cases of large patients, complex cases. We didn't have movement of the beam. That's when we have effect. It's not just limited to the back region. In this example, the patient had a case of dealing with stroke issues and doing neuro work. And in this case, the dose was high enough where there was hair loss involved. Lots of examples out there. But this is the exception, not the rule. All right, so what can we do? If we had control over the pedal, if my foot is not a lead foot. In other words, if I don't have my foot on the pedal a long time, then the less exposure will occur for our patients. If I had an option, when we have this C-arm X-ray unit, if I could actually have the ability to move the C-arm so that different areas of the back are exposed, that's beneficial because no particular entrance location is getting hammered with the same amount of radiation during the entire case. So we don't always have an option on that. Sometimes we're fixed in a position, but if we have the ability to rotate, that's helpful. Another helpful aspect is, recall the x-rays are coming from below the table. If we're able to raise the table slightly, that means the distance from the x-ray tube to the entrance of the patient gets larger. If it gets larger, that means there's less exposure to our patients. In that same light, if we keep the patient up close to the image intensifier, which is above the patient, if this is up close, then our distance increases from the x-ray tube. We have the ability to collimate, right? So if the area of interest is this large, do we really need to have the beam open this large? The answer is probably no. We want to collimate down to the area of interest. There's something called magnification modes, and you've probably seen when you worked in x-ray or around fluoroscopy, if we hit a certain button, all of a sudden the image looks magnified. If the image becomes more magnified, then there's more radiation dose to the patient. So anytime that image magnifies, the number of x-rays exposed in our patient increases. Many of the modern day units have what's called pulse fluoroscopy. So if we can decrease the pulse rate, the number of x-rays generated per second, then that lowers the dose. If we can use a lower frame rate, a lot of these units have frame rates, especially in the digital runs. If we can lower that rate, then the dose to our patients go down. One of the aspects of the idea of a sentinel event, in other words, if a patient received greater than 15,000 milligray, we may or may not need to look at, did they have a procedure last week or last month? Because we could have a cumulative effect. So if I'm a patient today, I receive radiation exposure, assume I receive a lot of radiation exposure, then tomorrow or next week, if I receive more exposure, you have a cumulative effect. So the cumulative effect could potentially cause a situation such as a sentinel event. And then confirm the arms of the patient out of the field. We saw a slide to definitely indicate that to us as well. In summary, time distance shielding, that's our golden rules. Distance is effective, shielding is effective. Shielding is 98 to 99% effective. When we look at our occupational dose limits versus what we actually receive, we probably receive a few tens or hundreds of millirem per year. Keep in mind, long, complex fluoro cases where the beam is stationary, there's a small segment of the patient population where we could have radiation-induced skin effects. And then, as we mentioned, we have several options we could use to limit the exposure to our patients. All right, what kind of questions do you have on radiation? Yes, sir.
Can you explain again the dosage amounts that were experienced, that we generally experience here in Niagara, like versus what we're allowed to use?
Okay, so we're talking about the patient exposure. Is that correct?
No, just our exposure.
Oh, yeah. Your exposure? Let me think where that is. There it is. Talking about this particular slide?
Yeah. Yeah.
Do those numbers seem reasonable to you, or? Now, I will be the first to admit, I mentioned it earlier, but I sometimes forget. I have on my badge, right? I put on my lead apron. My lead apron covers the dosimeter. So I would expect just almost zero exposure to my badge. The regulators actually want us, if we're just wearing one badge, to go ahead and wear our badge outside of the lead apron.
We didn't have one that was running that. Especially
Yeah, I think you answered your question. Probably one on the back as well, because of how you do your job. Anything else? More than one badge? No, we do not.
Well, that's what he's saying. If we had one on the front and one on
Oh,
the back.
I'm sorry. He was asking about the badge. I thought he was just asking about the apron that just covers the front versus the badge. Oh, got you. The answer is no. We do not issue more than one badge. So you're thinking you're going to start wearing your badge in the back, huh? Yeah. Okay, you guys have a great lunch if there's no other questions. Thank you.